Hi, it's Sunday morning. Alan and Andy here for Return to Healing. And Alan, just yesterday and the day before, I had a really amazing patient of mine. He's 86. He every now and then when I'm out walking, I see him bicycling around the paths and I see him pulling weeds in his garden. But of course, he's got a set of kids who thinks he shouldn't be living alone. He's demented because he repeats himself. Well, he had a face plant um, at the store, and he may have passed out. Um, so the kids brought him to the hospital. And this is a guy who doesn't take medicines or even really go to doctors very much, other than seeing me. But all of a sudden it became there were things, and one of the things was they drew a lab called the Troponin on him, and so then they said they had to do all these heart tests and a series of troponins, and the cardiologist came in, an echocardiogram stress test, um, admission overnight just because they're worried. Mind you, CAT scan, MRI, all everything normal, except for the troponin, which went up. So, Alan, we wrote actually an article both about people who pass out, and what we should do with them, and also about this troponin test. And the troponin test, I think, tells us a lot about the emergency room mentality in our country in general and why it could be dangerous.
Andy, I agree with you 100%. When you texted me about the topic, I have a great case to present as well. But, when you look at this, it basically comes back to a lack of common sense in medicine as we see it all the time. And that lack of sense goes to people don't talk to patients anymore. Like they don't really get a history. Someone comes in, as you said, the guy fell on his face, which just triggers a line of diagnostic tests that's done without even a real history, number one. And equally important about a physical exam. Like we don't examine people. So ER doctors, and I hate to say it, they're really busy. People are coming in. Why are you here? Oh, I passed out. So the medical term for that is syncope for the folks. And it triggers a syncope workup that Andy just described without even talking or examining the patient. I've seen on these what we call stroke protocols that you don't even see an exam on the stroke protocol. Like before the person is even touched, they have 47 MRI, CT angiograms, MR angiograms, flow studies to the brain, perfusion studies to the heart and brain, and like 98% of them are normal. Like when you look at someone, hey, this person's having a stroke. Like examine people.
It is that whole idea of, um, you look at someone and you have a sense of what's going on is lost completely. It's almost irrelevant.
It's
It
all protocol. It's
it's
like the
it's
app.
all protocol.
There's an app for that.
And so a troponin is a test that's supposed to diagnose the heart attack early. Now, first of all, a guy who falls on his face is not having a heart attack. It's pretty clear that that's not what's going on. So why would this test even be done? Once it's done, if you fall on your face, it could go up with any kind of damage to the body. If you run a marathon, you're gonna have a really high
And,
troponin.
and most people of that age have some slowing
Yeah.
of the kidneys, and people with slow kidneys have higher levels of troponin. It's going to
Right.
be,
What we found is older people all have high levels. Athletes or people who had traumatic injury have high levels. People with gallstones gonna have high levels. It's just not a specific test. So if you do it without what's called a pre-diagnostic certainty or some suspicion clinically, like, oh yeah, he was having severe chest pain and then he fell down. Yeah, okay. Then that's in the equation because we talk to the person, we examine them. Um, but just to do it as part of a workup, it's going to be positive,
yeah.
and and then it's going to lead to thousands of dollars of tests, some of which also might be positive. In this guy's situation, thankfully, the next tests weren't, but of course he'll have a follow-up with a cardiologist, and then we're in the then we're in this morass for something that shouldn't have been done. So, Alan, what we found in our article is the pretest probability of a troponin meaning something, having any meaning at all, was 5%. In other words, of all troponins that are positive, 5% will have any meaning. And those were all done in people who had chest pain or some other clinical manifestation of a heart attack. The other 95% led to unnecessary testing, which could have been dangerous, and often is.
And it's the same with the CT of the head with syncope. Same kind of numbers, especially when it's not directed. We know there's certain signs in syncope that might say, "Hey, could be a problem in someone's brain, and they should have it." But, if someone's out in the hot sun exercising and it's in the middle of the summer and they didn't drink enough and they pass out, like, duh, like we know what they passed out from. They're a little dehydrated and overheated. Why are we doing any tests on them?
Yeah, I mean it's the old, cover your butt situation. Some people have told me, but that's bad medicine. To me, it's also, makes big money for the hospital, and for some of these specialist doctors who come in to see people there. Like these cardiologists just did all these tests, based on a stupid lab test. And the head CAT scan's the same thing. Well, what if the head CAT scan then finds a little something? That has nothing. All older people, by the way, have abnormal CAT scans.
Right. And
So
now they're quote referred for observation. You can't send them home.
they're referred for observation, and that's money for the hospital. It's a perverse incentive. And in my case, I one of the sons is one of the smarter medical people I have ever seen, but then he had two siblings that overruled him. And he wanted dad to come home. Dad wanted to come home. Dad became not part of the whole equation. It became testing. Dad might as well have not have been there. You could have gagged dad and just, put him in a corner as they did all the tests because dad didn't matter. And that's what's happened to our medical system. The human being in the equation has been lost, and it's just all testing. And the emergency room, which can save your life if you go for the right reason, could also be quite a dangerous place.
Yeah, no. So I call the cardiac testing the trifecta of tests in our hospital. Everybody gets them almost no matter what you come in for. And that's the troponin. And then there's something called a BNP that we use for heart failure. And then there's something called D-dimer, which is used for blood clots. And invariably, one of those is going to be wrong, abnormal, and it's going to lead down a path of on the unnecessary next test. And each one of these tests that then leads to imaging adds like 8 hours to the person's hospital stay. So someone coming in for something totally stupid, not stupid, I mean on the patient's part, but that's easy for the doctor to figure out and get the person out of the ER, ends up with, 36 hours worth of an ER stay and testing.
And yeah, and it can lead to, like, so my dad, um, who is not one to drink a lot of water, 84 years old, had a bad heart, but never had been in pulmonary edema, which means he has poorly functioning heart, but not once has that led to fluid in the lungs. But he went to the hospital because he was tired. He actually went to his doctor because he was tired, and the doctor needed blood work and couldn't get it, so sent him to an urgent clinic, which led to them thinking he should be in a hospital for what he had been experiencing for the last 5 years every day. Just a little shortness of breath and tiredness. Anyway, that one of those tests, that BMP was hot, and it's always high in him, but he was super dehydrated and he had a high BMP. You know what they did, Alan? They sucked fluid off him like you wouldn't believe and put him into an acidotic spiral from which he never recovered because he died a couple weeks later. This is what happens with a test in a guy who's clearly dehydrated, not fluid overloaded, but the test says otherwise. So they treat the test and cause massive harm. And that's the problem with just, like you say, fishing. You're throwing
Right.
all these tests out. One of them is going to come out positive.
And we don't think anymore. And unfortunately, this is how we're training our youth. I do most of my time training residents. We're training our youth just to be robots. Someone comes in, the word syncope comes up. Now they get the next 14 tests to rule out cardiac causes versus neurologic causes, and they have to get all these things, including in my office with a cardiac complaint. So what do you, I'll say, patient comes in with chest pains. Like, what do you want to do? And like literally troponin comes up in the office. Like, I was like, you were doing a troponin in the office? Like, if you're thinking my patient had an MI, we better be sending them to the hospital because finding out tomorrow is not a good thing. It's like the clinical judgment has just totally gone out the window.
And what's your ER story? Because you said you had one.
Oh, so I literally, I have an elderly. You'll appreciate this one. He's about 78, and he's got really bad Parkinson's. I mean, the guy could barely walk. He walks with a walker and an aide by his side holding him, coming shuffling along into the office. I'm sure he's got another month or two before I'll be seeing him in the office in a wheelchair. Uh, and he calls me up, constipated. So for like 3 days in a row, I'm talking to him on the phone, telling him what to do for his constipation. And now he calls me up and says, I can't pee. And I'm like, uh-oh. I was like, when was the last time you peed? He goes, I don't remember.
Mm.
I said, you need to get to the emergency room. So I literally called my people in the emergency room because I knew what would happen to this guy because he could barely speak for himself. He'd get thrown in a corner until somebody evaluated him like 6 hours later. When he was there, because he hadn't pooped in a week and he hadn't peed in 2 days probably, and he had probably had a urinary obstruction from the poop. So I sent him with the diagnosis. Well, bless you. So he did get seen right away. And unfortunately, instead of a reasonable exam and putting a Foley catheter in him, they ordered a CT of his abdomen and pelvis. I sent him with the diagnosis, CT abdomen and pelvis. And what got me even more is I always laugh that every patient of mine that goes into the ER now, because everything is ultrasound in the ER, point of care ultrasound. That's an ultrasound that people go for that some of the surgeons literally and some of the medical doctors, they carry portable ones in their jacket. It's like their stethoscope now is portable ultrasound. And someone comes in with something like that, you put the ultrasound over their bladder and see that it's full. But
Yeah.
instead, no, we did a CAT scan. Well, 8 hours later, the CAT scan showed constipation and a distended bladder up to the umbilicus. That's up
Wow.
to your belly button, folks. So your bladder's up to there. They put a Foley in and drain out 2,000 liters of fluid. The guy immediately feels better, goes to the bathroom with his aide, and has a huge bowel movement, which I would have expected, after you emptied out 2 liters of fluid from his bladder that was pressing on his rectum so he couldn't pee. And all well, right? No,
Yeah,
so
cured,
so
cured.
the ER doctor calls and says, I'm referring for your patient for admission. And I said, for what? Well, he's going to have post-obstructive diuresis and he's going to need several days of IV fluids. Like he's been drinking. Like, why do you say that's going to happen? I said, give him a liter of fluid if that's what you think, and we'll repeat it in a couple of hours. She refused.
Wow.
So our protocol in the hospital is if ER doctor recommends admission, which will be denied because I sent him home the next day because he was fine and wanted to go home. And the patient wanted to go home, by the way. Uh, and they determined the category, like admit versus refer for observation. And she just insisted it was 10 o'clock at night, and either I come in and send the patient home, which I could do, or I just go along with it because I want to sleep for 3 hours.
I, it's just that's on so many levels because the diagnosis was given and they just needed to listen to the doctor who knows the patient and go with that and
Oh, I'm a family doctor. I don't know shit.
you don't know anything. You know the patient. We don't know anything. But if they listened to you, they would have put in the Foley and poop pee, pull out the Foley, go home. And like you say, why would you ever put a needle in someone's arm with artificial fluid when someone could drink? It doesn't make sense. Yeah, I mean that's for people who can't drink. Yeah, I get it. But if you can drink, that's the best way to get fluid always. But everything has to be one step higher there. Like it's not good enough to listen clinically and say, obviously, this is poop blocking the bladder is blocking the bowel. It's like a double whammy. You fix one, both get better. No, instead they have to do a bunch of testing to show what they already know. And that's a huge problem. You don't want to because that test could show something else. And then now what? Then they start calling in consults and specialists and blah blah blah. So he got away with the fact that you're his doctor. In our world and in most of the country, primary care doctors aren't even allowed in the hospital. We are not part of the whole hospitalization emergency room experience. We're not allowed. They have their own doctors, and those doctors are there to refer to specialists and to do tests. So, and not to know the patient. So we have removed us even further. So be glad, Alan, you were part of the conversation at least. You were offered something which I can't even be offered.
Yeah, so I speak to, I'm friends with the chair of the ER, and we have this discussion like every week almost about some ridiculousness that went on in the ER. And he goes, Alan, we average 350 visits a day in the ER. Okay. And, think about it. If you rush through something, if you don't order the test and you miss something, you're wrong. We do the test, we're wrong. We do the blood, we're wrong. We do the CAT scan, we're wrong. Like, we just can't win. I
I
said,
get it. And I get that also. I get that all. I actually there are doctors who are not like us, Alan, and who if someone goes in the hospital and they didn't get $1 million of tests, these doctors get upset. So the emergency room has to deal with all these people, but it would be nice if there was some communication and if they listened to us. If we knew the patient and we kind of knew why they were coming and we didn't care. Like I've sent people to the emergency room or they went for severe vertigo and they end up having a high troponin and end up leaving with a stent. And with the vertigo completely not even addressed while they're in the hospital. So the idea of talking to the patient and addressing the issue at hand in a logical way, not a protocol way, is all we're asking for. And that can be done even with 350 people coming in a day. People can still be treated as individuals. So that's hopefully, for those of you who go to the emergency room, again, I say it all the time, you're in charge. And they may make you think that's not the case, but there has to be some common sense and you should question things. Like the idea of taking off fluid in someone who's dehydrated, that shouldn't make sense to most patients, even if it seems to the doctors. So yeah, question things and don't, protocols will not accept your questions, but you should ask them anyway.
yeah.
Any last thoughts, Alan?
Yeah, I mean, so it's similar in our hospital. So, the elderly fall thing is one of the biggest ones I have the argument about. 'Cause again, you get a senior that comes in with a fall, and in our hospital, that's an automatic trauma consult. Automatic trauma consult. And an automatic trauma consult comes with what I call the total body CT. They CT head, neck, chest, abdomen, pelvis, and spine. And I understand if the patient's out of it, they can't tell you. But if you have many of our or most of our elderly people that are yours and my patients, Andy, tell us what's wrong with them. And they just end up being in the ER getting so many tests. And it's not the test. It's not the blood test that might be $1 or the CAT scan, which probably doesn't cost that much to really do in a busy ER because the tech is sitting there and the machine is sitting there. So, it's really a fixed expense with most of these tests, in my opinion. I know they say how much it costs, but an empty CAT scan with the tech is still costing you to be sitting there in your ER, whether you use it or not. So I understand kind of the rationale, but it's what these tests find. So many incidentalomas, which are just useless things that we end up having to investigate because they're there, which leads to the next test and the next test. And unfortunately, many times this thing leads to a problem interventional test that could hurt somebody. And we just, we know it all from the work we did with the Lown Institute and our Right Care Alliance when me and Andy volunteered for like 10 years and didn't get too much thanks for it. But
Or like,
what did we find? We find that over testing leads to overdiagnosis, which leads to overtreatment, which leads to so many harms to the healthcare system, whether it's a backed up ER, financial losses, or true harm to the patient. And it's just common sense needs to come back to medicine. We got to lower the costs. Our country can't afford the costs, and we're just escalating it. We're coming up with a task for just everything. and it's screwing up our system.
And the test, that one test that I said had the 5% positive predictive value, which is 5% of the test actually shows something. That same exact test in England has a 60% positive predictive value. And the reason is they don't do it on everyone. They do it on people who have symptoms of a heart attack. So again, spreading out, just throwing a lot of tests at you versus using them judiciously are two completely different things. And Alan and I completely agree with the judicious use of testing. We're not opposed to that. But when you throw them out like this, one of my patients said to me, well, you can never get too much information.
Oh,
Well,
yes, you can.
yes, you can, because information, like what it did to my dad, will lead you in the wrong direction if that information is removed from the patient sitting in front of you. And the ultimate guide to your decision, as Osler said, if you want to know what's wrong with the patient, talk to the patient. And that's what's skipped. That part is skipped. So
That's what's gone away. We don't talk to people anymore or talk to the primary care or other doctor. Talk.
talk.
History is still important. AI is not going to take over a patient's history. It's not.
They can't.
You know, those are questions that need to be asked that you need to feed into AI. If you don't ask the questions, AI isn't going to be asking them.
And that's the problem is, you as an emergency room doctor or a hospital doctor don't know the patient at all. So if there are other people who do know the patient, whether it's the patient or the family or the primary care, you should have them involved if you really cared about getting this person better versus just going through the motions, which seems to be what's going on now. They're going through the motions thing. And it's unfortunate because the patient's the one who loses in this equation, even though they say, wow, that was a thorough evaluation. That's what I hear all the time, Alan. That was a thorough evaluation. I said, no, that was a stupid evaluation. That's all it was.
Yeah, I get that in the office too. We could talk about office evaluation as well. Like, do you ever finish with the patient and they say, like, that's it?
Yeah, all the time.
And I'm
I,
like, well, tell me, what did
yeah,
I miss something? Like, what,
like,
what, what else would you like? Well, aren't you going to do more tests and stuff? And I was like, sure, but for what?
yeah. They do. Well, I always say, what do you think the physical is? Some people say, well, it's an EKG and a urine specimen. I'm like, and well, that's it. That's what we want. Everyone has their own idea of what thorough means, but thorough means being a smart doctor, and
That's right.
also means the courage to do less. And that's also thorough, even though the medical community has kind of leaped off that train. Okay, Alan, hopefully you could have a
Uh,
decent day today.
you too, Andy. You guys take care. Don't forget, our book, Return to Healing, talks about all this in a very simple way, made for, every reader out there. And, it's a good book.
It's a good book.
Trust
So,
us.
one of my patients read it. Her son's in medical school, and she said, "Why isn't this not required reading?
Yeah.
This is everybody should read this." And so we agree.
All right. Have a good
Take
week,
care.
everybody.
Bye
Bye
bye.
bye.